All right, I'm going to get started with our webinar. Good morning or afternoon, depending where you are. Welcome to our webinar, Turning the Tide on Resistance, Local Leaders' National Goals for Antimicrobial Stewardship. I'm Harpa Eastfeld-Keeley. I'm a knowledge broker with the National Collaborating Centre for Infectious Diseases, or NCCID. The National Collaborating Centre, or NCCID, is hosted at the University of Manitoba, which is situated on the ancestral lands of the Anishinaabe, Anishinaabe, Dakota, Dene, Nehethawak, and Anishinaabeg nations. It's also in the heart of the Métis Nation. At NCCID, we strive to honor the lands and their original caretakers in our work and are committed to working with our partners towards reconciliation. We would also like to collectively acknowledge that the Indigenous peoples of all the lands that we are on today. While we meet on a virtual platform, we would like to take a moment to acknowledge the importance of the land which we each call home. We do this to reaffirm our commitment to improving relationships between nations and responsibility for increasing our own understanding of local Indigenous peoples and their cultures. Just a moment to introduce you, if you don't already know about the AMR CAN-AMS webinar series, that is. The long form of the name is the Canadian Antimicrobial Stewardship Webinars, so CAN-AMS for short. Leaders in AMS stewardship from across Canada share examples of what has been done to implement evidence-based interventions to inspire others about what can be done to help slow the rise and spread of AMR. So the co-hosts for the series are the Association of Medical Microbiology and Infectious Diseases Canada, or AMMI Canada for short, and NCCID. And this webinar series is supported by a working group from the AMR Aware Canada network of collaborators. And these are collaborators on a national scale that unite to build awareness of the growing crisis of AMR infections in Canada and what we can all do to help. So coming events are posted on the amraware.ca website. This is what that website looks like. We'd like to build your recognition of this, especially as we lead up to World Antimicrobial Awareness Week, when AMR Aware Canada joins global leaders in a campaign for raising awareness among the public and healthcare providers and in others working in a One Health space about AMR. So there on this website we have stories, we have a repository of resources that are curated from our partners, and this webinar series. We also have a campaign page of materials that can be shared during World AMR Awareness Week. So now some housekeeping points. Attendees are on mute and the chat box is disabled for participants. Please enter the questions that you have in the Q&A box, and these will be dealt with after our panel discussion. So in that Q&A, upvoting is active, which means that you can choose some other questions that others have already posed, and that helps us streamline the Q&A if you can upvote some question that's already been posed. So today's recording will be posted on AMR Aware .ca, the website I showed you, as well as on YouTube on NCCID's account, and that's at Center Infection. If you have technical difficulties today, email Crystal at crystal@ammi.ca, so Crystal with a K, and ammi.ca, AMMI.ca. So now I'd like to begin by, I'm very pleased to welcome Dr. Simon Otto as our moderator for today's event. Dr. Otto is a veterinary epidemiologist specializing in One Health approaches to address antimicrobial resistance and foodborne diseases along the farm-to-fork continuum, and he is an associate professor in the School of Public Health at the University of Alberta. Simon has been a close collaborator of NCCID and a key figure in the One Health and antimicrobial stewardship landscape. He has also contributed his expertise to key governance committees on antimicrobial stewardship and resistance, helping to shape policy and action plans in Canada. And some of you will be familiar with the Pan-Canadian Action Plan in particular. And so we're in great hands with Simon Otto leading today's discussion. Please go ahead, Simon.
Thank you very much, Harpa, for the kind introduction. Thank you to the NCCID and AMMI for hosting this webinar today under CAN-AMS. And thank you to our panelists for being a part of this morning, who I'll introduce in a minute. Welcome everyone today to today's panel discussion, Turning the Tide on Resistance, Local Leaders, National Goals for Antimicrobial Stewardship. In today's panel, we'll discuss progress on antimicrobial stewardship in the three provinces that the individuals represent, and explore ways to move forward on shared commitments to tackle antimicrobial resistance. So for today, we hope you'll come away from this panel discussion with an increased knowledge of provincial initiatives and progress in implementing antimicrobial stewardship initiatives, added insight into the distinct challenges, strategies, and opportunities for AMS in different jurisdictions, and an improved understanding of how healthcare providers and the public are being engaged in antimicrobial stewardship. I'm very pleased to welcome our three distinguished panelists today. First, we welcome Dr. Robert Strang, Chief Medical Officer of Health for Nova Scotia. Dr. Strang has served in this role since 2007 and is well known nationally for his leadership in public health, including work on harm reduction, immunization, and health system collaboration. Dr. Strang brings deep experience and a practical perspective to the discussion today on AMS. Please welcome Dr. Strang. I'm also pleased to welcome Dr. David Patrick, Medical Epidemiology Lead for Antimicrobial Resistance at the BC Centre for Disease Control and Professor at the University of British Columbia School of Population and Public Health. Dr. Patrick is an infectious disease physician and epidemiologist whose work has helped shape Canada's approach to AMR, particularly around community prescribing and public awareness. He's led key initiatives like Do Bugs Need Drugs and Antibiotic Wise, promoting appropriate antimicrobial use across sectors. We're glad to have him with us today. Welcome, Dr. Patrick. Our third panelist brings a broad range of experience from across government. James Turner is currently an Assistant Deputy Minister with the Ministry of Health in Saskatchewan, where he's been since 2019. Over his 23-year career in public service, James has worked in a variety of roles across multiple ministries, including finance, social services, municipal affairs and housing, and with Ombudsman Saskatchewan. We're very pleased to have James with us today to share Saskatchewan's perspective on implementing antimicrobial stewardship. Welcome, James. So we have a number of questions that we want the panelists to address today. We're going to take approximately half an hour to work through those questions. And then, of course, we'll open it up for an open Q&A from all of those of you who are attending today. So we'll start with an opening question. And we ask the panelists, what concrete steps has your province taken since the release of the Pan-Canadian Action Plan to improve antimicrobial stewardship? I'll open that up to whoever wants to jump in first.
So I'm happy to kick us off and then just thank the opportunity and welcome to everybody on the webinar. So certainly Nova Scotia, I think it may sound a bit bureaucratic, but we put some structure around our approach to AMR and ANS or AMS. We have created, and very deliberately, it's co-led by myself as Chief Medical Officer and the Chief Vet for Nova Scotia, a very, very deliberate decision in creating this of bringing together both human and animal health. And we've certainly then developed based on the 5 areas in the national approach. We've created a similar provincial strategy, and we have leads in each of the areas and a steering committee. So again, that may sound a bit bureaucratic, but we've done that, and we've gotten support at a deputy minister level from from a number of both health and agriculture and fisheries and aquaculture in Nova Scotia. So we have the political support from deputy ministers and ministers to create this structure, and then through that we've then approved and are working forward on a Nova Scotia provincial action plan, which mirrors and is linked into the national plan as well.
I could also say, I mean, the Pan-Canadian Action Plan is extremely welcome. It's probably worth mentioning that it was preceded by decades of work in many parts of the country. So we're glad to see sort of the national action plan come in to support that work. What those earlier efforts had already brought about were big reductions in outpatient antibiotic use and the establishment of stewardship programs in major hospitals, really under healthy pressure from Accreditation Canada. But I would say the action plan itself has catalyzed national collaboration in areas where it was really needed. We now have a national antibiotics guidelines process that means that we're not just lonely collaborators out in Alberta and BC putting guidance together for ourselves. We can now work with our colleagues nationally. We've had collaboration nationally on public messaging thanks to the National Collaborating Center in Infectious Disease and the Federal Health Portfolio. And I would say also it's really interesting to see that some strategic research investment in this area so that we're now working with colleagues across the country on what works for stewardship.
Yeah, and I'll just chime in here from Saskatchewan. So I think we've got some momentum happening here since April. So I'll be completely candid and honest. I have no clinical background or technical background in this, but from a government perspective, a year ago I knew nothing about AMR, was not AMR aware, and have since been sort of scared straight about the threat and the real need to actually move some action in this space. And so we've been working since the spring to get some balls rolling. We had lots of pockets of action happening and lots of attention, just nothing that was a bit of an action plan that bringing it all together. And so I think we've tried to learn from Nova Scotia, specifically Alberta, to get moving quicker on putting together a bit of an action plan here in Saskatchewan and a bit of a work plan, a 5-year plan to put some words on paper of things we're going to do. And we started that this summer with actually doing a bit of a current state gaps analysis. And so that's wrapped up. We're validating that back out with folks that contributed, and we're hoping to parlay that into a pretty quick work plan here that moves us along with some concrete actions that we can start with slowly and build some momentum there.
Thank you. It's really good to hear, I think, about different provincial initiatives in this space and linked to the Pan-Canadian Action Plan. And I take 2 seconds to interject on the Alberta perspective because I used to work for provincial government and started work with colleagues on the Alberta Framework for Action, the One Health AMR framework, which kind of was developed tandemly with the Pan-Canadian Action Plan. And it's really interesting to see all these provincial initiatives starting to go forward. And you may have alluded to this already, all of you, but I think we're really curious to hear from you if you could share a key success story or perhaps milestone in your province that you've achieved in addressing, the Pan-Canadian Action Plan's priority around antimicrobial stewardship.
I could start. I mean, before we got going with stewardship, especially in the community in the province, I could say that 8 out of 10, there were 8 antibiotic prescriptions written for every 10 British Columbians. And now that number's down to 5, which is about a 40% reduction. And that's been achieved with no evidence of, worse infections, and we're seeing fewer side effects and that kind of thing. So I think the proof in the pudding with stewardship is reduction in overall use and increased metrics of appropriate use where we can see it. So, for example, with urinary tract infections, which are a big reason for using antibiotics, we've been able to track a gradually more guideline concordant approach to treating that disorder. So, if we have a decrease in use and an increase in appropriateness, we're happy. It's not like we've got everything on the go, though. We've got some challenges where we really are not yet, as a grouping of regional health authorities within the province, we're really not rolling up our antimicrobial resistance data super well, and I think that's limited our ability to contribute nationally.
I mean, might just follow on that. I think data has been a bit of a success here too in Saskatchewan. I don't think we're doing great at it, but we do have a bit of a pilot that has been sort of conceived over the last couple of years around physician billing data and some of the prescribing practices there to actually get some real insight into what's happening. And I think we're on the verge of sort of landing some DSAs and making sure we have the ability to pull some data there that I think can inform some of those real on the ground clinical practices in community. And so I'm actually really excited about seeing that come to fruition here, because I think it's been a hard road to sort of get everybody okay with that. And so I think it'll be pretty exciting here.
So, I think in Nova Scotia, we've, data is perhaps one of the areas we need a lot more work in, make some progress. But I think we've made some success on the stewardship side. A couple of concrete pieces there. We were able to leverage. We had a very substantive long-term care outbreak in the first year or first few months of COVID, with lots of mortality and lots of attention to that. The opportunity of that led to the ability to make an investment in infection control, as well as increasing our complement of infectious disease physicians, along with some investments in public health. And through that, we've actually been able to create a clinical lead of antimicrobial stewardship for our single health authority, the Nova Scotia Health Authority, and build capacity so we have a much more robust infection control supports, including antimicrobial usage for our long-term care sector. So that's and we've made progress in prescribing. We need to get better data to better describe that progress. The other more recent one is that my antimicrobial stewardship colleagues, we've actually very recently gotten funding to implement First Line, which many folks are probably aware of that. It's a clinical app to really help prescribe or help support frontline prescribers with clinical data on infectious diseases, on infectious organisms, and appropriate prescribing. And that really is the key. We've, as David has alluded to, we've built, even before such a focus on AMR, a lot of good initiatives in stewardship, but mostly in a hospital-based stewardship. And really where we need to go more robustly is expanding that into into clinical settings, including with our veterinary colleagues. And First Line is an important step in that direction about supporting community-based prescribers.
Rob, can I just add one thing on that? I think that when it comes down to guidance in antibiotic use, the breakthrough is that we now have a national collaboration on producing the guidance.
Absolutely.
I don't think it's dependent on a specific technological platform for distributing that guidance. And so I don't think this is a First Line initiative. It's a Canadian antibiotic guidelines initiative that is the most important thing.
No, absolutely, David. Thanks for that. That's an important point. It's what's behind the app that really drives it and gives people across whatever the application is, community-based prescribers, easy access to up-to-date information to inform their prescribing.
And I really like that discussion about national guidance. And I know, and you mentioned, Rob, I mean, the expansion of that discussion over to the veterinary side as well. And it's early days there, but I think there is a lot of room for that, and will help prescribers. And I mean, again, considering how complicated the veterinary side is with different species, different types of practice, there's lots of room there. But I think one of the things I really like about all of your comments about, just the alignment with pillars within the National Action Plan and things that we see in the Alberta Action Plan too, right? Focus on data from surveillance, infection prevention control being an important part of that, right? If we can prevent infections, we don't need to treat them. And this focus on community and the clinical side too, right? And I think it leads nicely into our next question about, just some curious about how you're engaging healthcare professionals. And I see there's a good question for the Q&A about more allied health professionals, which we'll get to in that open space. But how are you engaging healthcare professionals in the space for AMS, the public, and then, of course, thinking about One Health spectrums, given that, the health side on the human isn't their direct area, but what about agricultural sides, veterinary side around responsible use?
I can jump in there first. On the One Health side, I think we've got a unique opportunity here in Saskatchewan. So we actually do have a fairly robust One Health team already established. That's a table that's been working quite well between the Ministry of Agriculture, Ministry of Health, and Ministry of Environment. And so I think making connections into that from this perspective, and it just so happens to be that I'm now the rotating chair of that committee. So it actually is a good time for maybe bringing some conversations. I don't want to take over the work of that One Health committee completely, but I think bringing in a bit more of the perspective from an AMR might help some discussions at that table, or it might help us move our AMR dialogue along quite a bit. And just maybe another point on that is through our gaps analysis, we discovered, and I don't think anybody knew here, well, we didn't know from the health side, that our Ministry of Agriculture actually does have a public trust team already that had already developed some key messages in this area, and we've not yet actioned it and put it out there for full public awareness, but they've already been working on some key messages in this space. And so we just discovered that as we were doing the gaps analysis. And so I think making those connections across that One Health spectrum are really important.
I'd say there's maybe a secret sauce for us in the professionals, and that has been working with health science students. So a big shout out to any med students, pharmacy students, nursing students that are on the call, because not only can they be introduced to AMR and AMS issues in curriculum, but we're having large contingents of them work with us to go out to schools, nursing homes, that kind of thing, to deliver the public messages about reducing antibiotic use and reducing infection. So I think that's a really interesting way to engage health professionals. On top of that, in both BC and Alberta, for many years now, we've had the Bugs and Drugs Guide, which is available free and online, and it's been integrated with many primary care continuing electronic health records. So up-to-date guidance is easily available. And we've bolstered that by providing free online for credit continuing health education programs, which are actually accessible across the country because they're College of Family Physician of Canada approved. And then I think to that question in the chat, to a certain extent, yes, people, not only doctors prescribe, but dentists are prescribing, nurse practitioners are prescribing, pharmacists are prescribing, and they all need sort of their unique elements of communication. And so to keep us on track, we try and maintain an advisory committee to the Community Antimicrobial Stewardship Program in BC that is representative of all those groups.
And maybe listening to David, I'm a bit jealous. I mean, that where we're trying to go in Nova Scotia is more that much more robust, multidisciplinary, kind of professional approach in the community-based side. But we are making some progress. First, on the education piece, I agree absolutely. How do we educate the next generations of a range of healthcare providers, and certainly in Nova Scotia, we make a big emphasis on pharmacists and expanding their practice, and it's important that we engage our pharmacy colleagues on that. And there is actually a program for pharmacy students around antimicrobial resistance, antimicrobial stewardship in their training program. As I mentioned, the first line, we have a long-standing program through Dalhousie of academic detailing that reaches out to primary care providers and that on a range of prescribing topics. And we've done appropriate antimicrobial prescribing multiple times, but we're linking that detailing with the rollout of first line to really, and I think that's a robust way to engage and bringing in, like as we bring more pharmacists on board prescribing. And then I think this is the David also mentioned, research opportunities. We're now participating as part of a CIHR funded research about developing a digital dashboard, which will both provide patient and public information around antimicrobials, antimicrobial usage, but also has the potential to fill in one of our key gaps, which is really get better data on antimicrobial usage in the community setting. So we're making progress still behind provinces like BC, but this is, to me, the opportunity of a national approach to how do we strengthen our collaboration and sharing and learning from across different provinces and territories.
So given positive strides, what do you think are some of the barriers that you're facing in your province with implementing stewardship initiatives, and how have you addressed them or how are you working to address them?
Well, I'll give. I mean, that's I think it's how do you. For me, the challenge and my colleagues is how do we make sure that we've had some attention to investing in AMR and AMS, but probably that was the opportunistic investment because of other things like COVID and high-profile long-term care outbreaks. To me, the challenge is how do we make sure that the issues around AMR and this collaborative approach and working in all of the pillars maintains a priority when right now there's such a push in the healthcare system around it's around access, and how do we do that? But how do we bring a lens of really what's appropriate and quality care, and within that around prescribing and antimicrobial prescribing as an important piece of that. I mean, we were not successful in getting in government terms. I would call it a very modest investment to support the expansion of AMS in the community in the last budget. So we need to keep working on making sure that this doesn't fall, or how do we maintain this as a priority within the broader healthcare environment. And I think the way to do that is to get better data on cost avoidance, all those kind of things that happen. I will make the other observation as a public health guy. I think we also need to then focus on what are our investments in, for instance, respiratory virus infections. How do they actually be seen as a positive investment ultimately that supports antimicrobial stewardship? If people aren't getting the viral infection in the first place, then they're less likely to be going to get looking for a prescription, whether it's necessary or unnecessary. So I think linking some of these more peripheral but very important issues into this as well.
Ooh, I'd like to riff on that a little bit because there's two barriers that have been pretty big in BC. One is the same one that Rob is mentioning, and that's public sector funding is going to be leaner in Canada for some time, and there's the risk of not getting things funded or having budgets shrink, but these programs, especially at the community level, save a lot of public money. They have results that are good in terms of reduced antibiotic use, helping to prevent resistance and reduce side effects. But we've costed our program in BC and seen between sort of $30 and $50 per dollar spent is actually saved to both the government program and to individuals who would be paying for antibiotics that they didn't need. So I think the business case in a way is something we should work on together because I'd love to see fully securely funded programs across the country. It saves money and it's good for health. It should be funded. And then there's a second problem that I'd like to characterize as whack-a-mole. And that is that we have seen a long-standing decline in physician prescribing, but we've seen increases elsewhere. We've had an increase in dental prescribing, and we've been working with a very diligent College of Oral Health Professionals in BC to turn that around. And we've also had patterns of new prescribing by nurse practitioners and pharmacists, and a priori, there's no reason to think that they won't be as guideline concordant and logical as prescriptions by physicians. But we do need to track them, and we do need to help those groups, contribute to the stewardship effort as well. So public sector funding and whack-a-mole are big problems.
Yeah, I think the other two panelists are singing my song here. I think attention is one of the biggest things I've seen is that nobody's talking about this. And I feel like we have a very small but passionate group of folks in our Saskatchewan Health Authority that are having this conversation. But I think we're struggling with like how do we get the narrative to the decision makers? Like how are we actually focusing attention on this? And I think this is not dissimilar to, I think, the same conversation we're having in the One Health sector as well, is how do we get folks, decision makers, to pay attention to it? And I think there's a couple things I've seen in both that are similar sort of themes. One is factual information. So how do we convey factual information that is very scientific and complicated to decision makers in a narrative that is actually understandable? And then the second one is Appropriately categorizing the risk. I think there's some scary stuff here, but I don't think you can just like threaten them with the scare. I think it needs to be sort of balanced and appropriate so they actually can sort of respond appropriately to it. And I think those are two key themes to focus on in terms of building that narrative with decision makers so they will pay attention to it.
Yeah, so a couple of weeks ago, a handful of some of the AMR people, MySpace governments and otherwise were in Ottawa for a meeting with other experts and representatives from the G7 that was hosted at the federal level to talk about AMR and approach to AMR in Canada and globally and G7 nations. And the funding is a big challenge, right? And one of the questions we have today is, the question we have is how do you ensure your AMS programs are adequately and sustainably funded? But you've all already highlighted that's a challenge right now. And one of the things that came out of that was the fact that we, as an expert community, we haven't necessarily done, I wouldn't say they use the best job. I think it's the right job. We've used a narrative that doesn't seem to be getting the attention that we need. So how do we what do we do in that space to make sure that we have sustainable funding in a time of really competitive resources? And you've all alluded to it a little bit, and David in particular, the business case, the cost savings. But if any of you have any other additional thoughts on that question, I'd love to hear them.
So I just want build on David and your comments, Simon. Is I think we need to take this to the FPT AMR steering committee, and how do we work collaboratively through that established structure to build out this business case and the arguments behind it that we could all use, built on data that BC and maybe Alberta, some provinces ahead of others. So how do we, but building that other piece. The other side of this, a bit of a different take, is that certainly, again, Alberta and BC are ahead of engaging the public as well in some ways. And I think it's a challenging space, as we know, getting the public to listen to evidence-based information. But I think we need to be working more effectively and collaboratively about how do we engage Canadians. Because we can do everything we can on the prescriber side, but we need to help people do a lot of work to understand and decrease the demand from the public for where antimicrobials aren't really warranted and necessary. So I think that's the other flip side of this that I think needs more attention from a national perspective as well.
And an
Rob,
increasing.
I can't agree with that more. I mean, the act of prescribing an antibiotic isn't simply a rational single task by a healthcare provider. It's a social interaction that is provided with feedback, and that feedback comes from your patients. And if you have half a dozen of them who are pissed off at you for not giving a prescription in the morning, you might be more likely to write one in the afternoon, just because of social pressure. So yeah, I think it's a really important thing to think of this as a social behavior that has important transactions from our patients and the public, as well as prescribers, and changing public expectation. Coughs, colds, toothaches don't benefit from antibiotics most of the time. Those messages help, simple as they are.
Yeah, I might just jump in there with I think there's some small bites to take here first. I think I don't think I'm under no delusions that, and I've told my colleagues in our health authority this, that I'm going to get them surgical type dollars. That's just not going to happen on this topic. But I do think there are some small sort of nibbles at this that we can take in terms of some investments in some publicity, some media, some awareness, or even a few other smaller projects that I think can get the ball rolling to start that conversation, and maybe those then bridge into something more that's a bit more fulsome, that maybe is a bit more sort of costly, but I don't think we're going to be able to start there from my perspective.
And I appreciate the comments and the added challenges in an environment where some political structures, obviously, south of the border and locally in some cases, but this anti-science, anti-public health sentiment has added challenges to everything we're trying to do. So keeping the dialogue going publicly is important. So I'm curious, I guess, as we wrap up here, what do you think are your province's key priorities for the next 1 to 2 years when it comes to stewardship?
Well, I
guess we
think it's, and I've got some ideas even from this conversation today to take back. I think it's continuing the work that to build on our, more hospital-based AMS, which is quite successful, but continuing with the initiatives I've identified, but making that more comprehensive is getting out into the community with a range of community prescribers and really more robustly having community-based stewardship, including the engagement of Nova Scotians in that conversation as well. That to me is our key priority. And linked into that, as we do that, we always need to say, what is the data? So there's a very much a linkage to the surveillance pillar of this as well. How are we getting better information to actually monitor and track the antimicrobial usage as well, to give feedback to prescribers as we're doing this, and also to monitor, to David's point, how do we monitor the impact of the investment? And it doesn't require surgical type investment, to James's point, but modest investments. We absolutely need to be able to collecting the data. So what was the outcome? What was the return on that investment? So we can continue that focus of attention.
Yeah. I'd say we've got a few priorities. I mean, right now there's a national collaborating going on with individualized feedback to prescribers called CanBuild. And so we're taking a look at how a portrait feedback for a clinician can improve prescribing. We've done that a couple of times in the past with the UBC Therapeutics Initiative, but now we're going to try and do it as part of a national initiative led by Kevin Schwartz out of University of Toronto. We also, as I sort of mentioned before, we want to make sure that these new areas of prescribing are net benefit. So the pharmacy prescribing, we need to keep an eye, make sure it doesn't increase sort of the overall net use of antibiotics unjustifiably. But I mean, I'm already getting good feedback from ladies in my environment who are saying, I don't have to wait till tomorrow morning to go into the doctor's office. I can go to the pharmacist and treat this burning sensation. They're pretty happy with that. But I'd say the area that we need to work in the most with our federal and agricultural and veterinary colleagues is the measurement and reporting in agriculture and veterinary practice. We've had some movement in that direction, but it's a less complete picture than we have for human utilization.
Yeah, and I think from my perspective, I think in the next 1 to 2 years, I'm hoping that we actually have a documented action plan to respond to PCAP. So I'm hoping by the end of this fiscal year, we actually have a piece of paper that articulates our actions, slow as they might be. At least, when you're kind of starting on the floor, there's nowhere to go but up. And so I kind of feel like let's bring those pieces together. There are lots of piecemeal things happening. Let's bring those together, put them in a plan, let's link them, and then let's show how we can, in the first 2 years, make some movement and some progress, even if it's just incremental small, because that will bridge into the years 3, 4, and 5 for us to actually build momentum. And so that's what I'm really hoping we can land in the next 1 to 2 years.
Do we wrap up the panel discussion part today before we open for questions? If you could ask one thing of your peers in other provinces to advance stewardship nationally, what do you think it would be?
I'll jump in first there. All right. So I don't know a lot in this space about what has happened or not, but a few conversations I have had, sort of AMR net surveillance might actually be one of those areas where I think it might help us with the antibiograms. Sounds like those are a lot of work, and having some actual momentum there to bring those together so we can see sort of a provincial view on some of these things rather than just doing it in Saskatoon, I think would be fairly helpful. And I don't know what that resourcing looks like on a federal level, but it sounds like we have the capability and the data is there to do it. It's, I think, just getting some horsepower to actually sort of help in that space.
Yeah, I think it's building on the existing. Now we have the National Action Plan, building on that and the strength and collaboration. So in AMS, I would, what would a robust AMS program look like at a regional level or even at a provincial level? and then what's the business case to fund that, build that capacity. And there's a number of initiatives. David's talked to several of them, that how do we, and you mentioned, the state PCAP, so we're not all doing it individually, but how do we build on the national, guidance on prescribing? That program you just referred to, David, around taking an approach nationally to provider comparative data. So how do we do this collectively, so we have a framework of what AMS could and should look like, the business case that, and then a national strengthening ongoing national collaboration. So we're doing this in a very coordinated manner, reducing duplicative effort, etc. I think that's where we need to be kind of focusing on moving forward.
Yeah, I mean, I'm going to work the same themes for the most part. But when it comes down to making sure that stewardship programs are properly funded, on the healthcare side, we're benefited by the accreditation requirements, so that we've got large facilities across the country that are doing it and seeing the benefit of it. In the community, there is no such thing, but the business case is unassailable. In BC, and I know enough about the Alberta budget on it, we're spending less than 50 cents per capita on these kinds of programs. They're reducing unnecessary exposure and side effects. They're reducing cost to government and to patients for drugs by multiples of what we're spending on them. And the health authorities who are running the hospital programs are seeing some similar benefits in their drug things. So I'd really like to see that business case advanced. And finally, I do really love the idea. Like, we were an outlier. Australia had them, England had them. There were national guidance on antibiotic use, and we had none for a while. We had a few regional projects. So the idea that that's coming together is really great. I'll repeat that I think we need to take a look regionally at the best way to disseminate that. We've got users in Alberta and BC of Bugs and Drugs who have hundreds of thousands of hits on those websites and make regular use of the apps. So we don't necessarily need to import one solution. The magic is in collaborative guidelines themselves. So I don't know, guidelines and completing that business case.
Okay, we're going to transition to the open Q&A part now, and there's a number of questions here. There's 3 related questions about the business case, which I think is a nice follow-up to where this discussion landed. Thank you all for your comments so far. So I'm going to summarize a little bit. So, there's definitely questions about, are there more data sources on the cost savings and effectiveness of various stewardship programs and initiatives from each jurisdiction that we can read about? Have any of those things been published, David, in particular to you? And then lastly, are there any plans to create a joint business case for AMR funding at a national level through PT collaboration? So I think those things are all related, and please, anyone jump in if you've got any thoughts or comments there.
We have published cost effectiveness of the community stewardship program some years ago. Probably should refresh it now and see where we go. But that's where I'm coming up with, saving $30 plus for everything we've spent. So much easier actually in the community to make that cost effectiveness case than with even hospital stewardship. So that's there. But I think that one of the things we've suggested at federal gatherings on this file has been that we could make a project out of a shared business case or a common briefing note to see if we can facilitate extension of community stewardship programming in places where it's not currently operating. Because it's really hard for a decision maker to say that's good for health and it saves money, but I'm not funding it.
The One Health business case part of it is more challenging when you start getting more broad, but I mean, part of it speaks to, as you said, David, we need more data on the animal health ag side for sure. Rob or James, over to you if you have anything you want to add there.
So I think certainly, as folks, I am the provincial territorial human health co-chair of the FPT AMR kind of structure. So one of the things I'm going to take back is that this, as David has alluded, how do we work nationally on a business case and then get that robust, and is there any way we can get that through, even through the FPT processes on deputy ministers, ministers of health, etc., just to make the case about this is actually not a cost, but it's an investment with lots of upside return. And everybody's focused on hospital utilization and access, and how do we frame it in under being a positive contribution to helping address those issues. So I think we need to start some conversations at the FPT level on building this out.
Yeah, I 100% agree. I have to admit that wasn't one of the ideas rolling around in my brain on this before this panel session, and it now is like, oh, that would actually be really helpful in this dialogue. And so I think that is one of the things that I think I can take back and cultivate, and maybe we can, as sort of a collection of provinces, drive that agenda a bit stronger, because I think it will serve us all well.
I'm going to go to the next question that I see. So due to limited access to physicians, we mentioned this question earlier, but just to specifically acknowledge it, there's been an expansion of prescribing privileges to allied healthcare professionals such as pharmacists. And is there a sense of how this approach to expanding access to antibiotic treatment of symptoms has affected stewardship, and is this being monitored?
I'll start. I mean, we're just in the middle of an evaluation of the program that allows pharmacists in BC to provide quick treatment for urinary tract infection. I mean, I should be very clear that the guidance for the pharmacist is the same as the guidance for the physicians, and they've been, as far as we can tell, especially good at using first-line therapies rather than going into broad spectrum alternatives and that kind of thing. What we are in the process of trying to figure out is whether this is going to, and we know at the same time that physician prescribing for UTIs has gone down a bit. So we're just trying to figure out whether this is leading to a net increase or not. Not that a small net increase would necessarily be inappropriate, because people with a urinary tract infection that requires treatment maybe didn't have access quickly enough before. But we do want to, we will complete that and publish that evaluation probably in the next few months.
Does any other
from my perspective in Nova Scotia, I mean, it's an area that we need to part of our getting better data, improving our surveillance as we bring more prescribers on board, in increasing access. Yeah, I think there is always that concern, and having people, if you might think you have a UTI, go to a pharmacist. Well, I think unless we're careful about that communication, we're potentially setting out the expectation that part of that is I'm not going to get a prescription from the pharmacist. So there is an opportunity. We need to evaluate that, but there's also an opportunity in this in our communication with the public around maybe trying to help them understand that an assessment doesn't necessarily mean that you need an antibiotic prescription for that.
Yeah. Part of it too, I think, is also what therapeutic areas does it make sense for a pharmacist to be in the middle of? When it comes down to assessing pharyngitis and so forth, they may or may not have the required experience and space to do a proper clinical evaluation, which is a very important part of assessing whether cultures need to be taken or whether any kind of treatment is required. UTIs are a bit simpler because they are often diagnosed by physicians, nurses, and others on the basis of the symptoms experienced by the patient themselves, occasionally supported by laboratory work. So there's not as big a difference between somebody mentioning those symptoms to a pharmacist who can't examine them and mentioning those symptoms to the family doc, say over the phone, when an exam doesn't happen. They're a little bit closer, but we still want to keep a close eye on pharmacy prescribing, because unlike the physicians, pharmacists might stand to benefit financially from issuing a prescription.
Yeah, and maybe from my perspective, as those professions expand their scope, like it actually might be easier to apply a standard where it's newly expanded scope. My experience is that as those things expand, it's easier to put standards into place, maybe for nurse practitioners or for pharmacists in that space. Whereas getting to a community physician that this is what I always do, that change management is harder, I think, and there's a bit more resistance there. And so I think it might be easier with these new sort of expanded scope practice.
I'm going to move and combine a couple of questions, comments about the Do Bugs Need Drugs program. So the first is a question about has Do Bugs Need Drugs been evaluated for impact or reach in BC and Alberta? And the second comment question was based on the different implementation approaches of the two, so Alberta education focused, BC surveillance and education focused, are there any plans for Alberta to increase the scope or the province's general scope to AMR surveillance? And David, I don't know if you know that. I'm not aware of that, but I'll open that one up.
Well, I'll start, and I don't want to speak for Alberta or Alberta Health. But I will say, for those of you who don't know about Do Bugs Need Drugs or the Antibiotic Wise campaigns, these were initiated in northern Alberta in the late 90s. And when we were looking for to start a program on community stewardship in the early 2000s, there was actually no great reason to reinvent the wheel. There was good material and good messaging being developed for the public. We were able to adapt to BC, and the Bugs and Drugs Guide was being put together based on international guidelines and reviewed by expert committees, which have expanded over the Rockies since, so that we sort of have a shared overall guidance. I have mentioned earlier in this talk that we have done some evaluation of these programs in BC. For the most part, these are ecological, but we can see clear deflections in the rate of prescribing in association with program elements that are brought out, and it was on that basis that we were able to do some cost benefit projections and come up with those kinds of discussions. I salute what everybody's saying about we need good surveillance, and I think we've had good federal collaboration on that, allowing some provinces to trend prescriptions that weren't able to do that before. But we do need to keep an eye on the surveillance and constantly feedback to say, okay, are our trends in the right direction? Are they in the right direction with each profession? Is something bumping up because we're not paying attention to it? So the surveillance action cycle is essential to this thing. To speak to Alberta, I know that they've been more cost constrained for longer than we in BC. So I can't speak to where Alberta will be going, but it has been good that they've had a long-standing commitment to the program, and I hope they stand with it because we love working with them.
I want to get to another question here. I see there's a few comment-based that I will highlight if I get the chance, but this question's been sitting for a bit. And so the question is, how should the industry go about participating in stewardship initiatives, or any tools available to facilitate industry's contribution to the development of a stewardship initiative in collaboration with NCCID? And I'm not sure which industry is being referred to there, but I'll just open that up if anybody's got thoughts.
I guess which industry is the most interesting question. I mean, when it comes down to some, there's no conflict. I mean, if you've got a vaccine manufacturer that brings a product onto the market, I think those have already had a big impact on stewardship. Since pneumococcal immunization came in, we've seen a big decline in certain bacterial infections in young kids, and that has contributed to the decline in antibiotic use. Drug companies, though, it's a little bit of a Sophie's choice for them. They do want to act responsible socially, but the traditional market approach is that they make money by selling volumes of drug. And of course, that's not a good thing in the face of stewardship. So I think Canada should continue to look at efforts going on elsewhere and being developed here to find alternative schemes to fund innovation. And so some of you may have heard of subscription schemes where nations or jurisdictions pay for the right to use a drug, but and that's the means by which the company is reimbursed for the R&D and expenses, but that it doesn't create an incentive to use the drug, 18 times a day.
There's a couple of comments about AMMI first line guidelines. So one of the questions is, will the new AMMI first line national guidelines be set to WHO aware for users? And then somebody did post a link to say here's a new development by AMMI Canada and first line for AMS prescribers, but I'll maybe open that comment thread up if anybody has any thoughts.
Can I just say one thing? I mean, national guidance that we're paying for nationally and putting together as professional things should not, in the same sentence, always be tied together with a specific corporate interest in terms of the platform. Canadian national guidelines on antibiotics are what we should be hearing. First line is a nice platform. Lots of people like to use it, but it's not the only one. And I actually object to the idea that we're calling our national guidelines after a corporation. So
Yeah, I appreciate that, David. I appreciate the emphasize and enforce messaging there. This question again, would there be room to create national benchmarks for what would be considered adequate staffing and resources for a proper AMS program, hospital and community? So it seems each of us struggle to convince decision makers for adequate funding for frontline AMS pharmacists, as an example.
So I think that's kind of what I was alluding to. Part of the business case is, well, what within, there's going to have to be a range, but what would an effective, comprehensive antimicrobial stewardship program, whether it's at a regional level or at a provincial level, look like? What are the types of skill sets that you need? How many roughly? What a range of types of positions and the actions that would happen through that? I think if we can scope that out and then attach a business case to that, and so you need some kind of an investment, but here's the business case that said there's a substantive return on that investment. I think that's what I was referring to as a part of developing that, what a good program would look like, if I can use that term, as part of the business case.
I think that work has been partially done from the hospital perspective, in that we've seen publications that speak to what standard programs need in the way of resourcing. Moreover, Accreditation Canada's absorbed that information, and it's hard to get your large hospital accredited unless you've got a program that's meeting most of those resource needs. So that kind of leverage has been great. We've lacked that kind of leverage for community stewardship for the most part, even though it's probably more cost saving.
Yeah, and I might just jump in there. I think that I kind of was with Dr. Strang there too. I think the business case can set a bit of a benchmark or a standard for governments to look at. I think having a best practice there then allows sort of me inside of government to actually leverage that towards investment in it. And so like it's almost kind of like it leads us to the right answer. And shame is a very powerful motivator. And so like if the best practices are right, I think we can use that to actually make some progress and some movement here as well.
Just looking at time, we do need to wrap up. I don't know if anybody has a quick comment about no one's answered the where categories for AMMI national guidelines. That was the real question. Sorry if we misunderstood that. I don't know that I understand the question, David. I don't know if that makes sense to you, if there's any comments you want to add
the aware
there.
classification is sort of a way of categorizing antibiotics as essential for everyday use, in reserve for other things. So it's basically a way of comparing our classification of antibiotic use with that used internationally. And I think it only makes sense as we put together Canadian surveillance documents that we move more and more to align with that kind of categorization that could be compared internationally.
Okay, I know there's one question about emergency kits and policy that we'll have to leave today, but I really appreciate all the questions from the participants. Thank you very, very much to the panelists today. for your thoughts, comments. I really have appreciated the discussion. And Harpa, I will turn it back over to you as we wrap up.
Thank you all. That was just a very, very interesting event today. Thank you all for your input and that wonderful conversation we've had. So our very pertinent, our next event is called No Stewardship Without Stewards, really addressing the resourcing question I think that a number of you have raised as well. Resourcing your antimicrobial stewardship program. So that's moderated by the Brad Langford from Public Health Ontario, presenter Valerie Lung. You can click this Q&R code or take a picture of that Q&R code to get to the registration page. So registration is just recently open. Also, thank you very much for attending. We would greatly appreciate you answering a few questions. This QR code leads you to an evaluation for the event today. Please take a few minutes and help us to shape future events that are as good and better. So thank you very much for taking those few minutes. We will be sending out an email to all registrants at this event with also with that evaluation. So please take a look at your inbox and give us a few minutes of your time. Thank you all again. Thank you, Simon. Very wonderfully done. And it was a smooth event and just a lot of valuable points came up about really advancing the work, both in your provinces and nationally. We want to sincerely thank all our panelists, David, Robert, James, and Simon for moderating so well. Thank you all and have a great day.
For having us.
Thank you.